Hey guys, and welcome to episode 202 of the OCDstories.com podcast. Now, in this episode, I interview Dr. Josh Spitalnick. Josh is a licensed psychologist based in Atlanta, and this is the second time he's been on the show. And in this episode, I wanted to get him on to talk specifically about OCD in children and its treatment. So we cover a lot in this episode. So if you're a parent of a child with OCD, then hopefully you'll find this episode useful. So we talk about his story of working with children, how OCD may differ in children versus adults, worry monsters, working with the family, explaining ERP to a child, encouraging kids to do their CBT homework. We talk about Pandas, which is something I haven't necessarily talked about on this show before. The key things families can consider when helping their child with OCD, dealing with family conflict in recovery, advice for parents, and keeping a child motivated during treatment, and much, much more. I really enjoyed this episode. Hopefully you find it useful. And without further ado, here is Josh. On the podcast today, I'm joined by Dr. Josh Spitalnick. Josh is a licensed psychologist, owner and clinical director at the Anxiety Specialists of Atlanta, an outpatient clinic. Welcome back to the show, Josh.
Pleasure to be back, Stu. Thank you.
Yeah, it's good to have you back. And the last episode we did was on health anxiety, and we got your kind of therapy story, what got you into treating OCD and anxiety. But now a slight different question for this episode, which is why get into working and treating children?
Sure. So a little bit of a personal backstory. I can't say it was the reason for why I'm into this space professionally, but I grew up with 3 siblings, and one of my siblings struggled a lot with anxiety growing up. So didn't think about it much back then, but I grew up in a household where back in the 70s and 80s, there wasn't a lot of good interventions for kids for anxiety. Fast forward to today, I've been pretty public about this and very proud of my daughter. I have a 12-year-old who struggles with pretty severe anxiety at times. And when she uses her therapy, she is not struggling nearly as much. And so as a father of an anxious child, and as someone who in his practice spends a lot of time treating kids, as much as I love working with adults and teens, which is very rewarding, working with kids and parents has its own level of reward. There's a different approach you take. There's a different payoff. You're doing a lot more early intervention, which I think is key. And working with kids who are much more flexible in mind and open to new ideas at times is just a really neat, empowering experience, but definitely takes a different approach than working with adults. So it's very rewarding. You're impacting the entire family. I wish my family had that 30 plus years ago, and my wife and I, who did what we thought was best at the time, even with my own daughter, and I do this for a living, I think could have used our own guidance at times, and we finally reached out. And when we did that, things magically got better. And it's not magical, as you know. CBT for anxiety and specifically for OCD-related conditions, it's not magic, it's science, and I believe it, I live it, and I practice it every day.
Yeah. Well, science to me can be a form of magic when it works well.
There are some surprise elements in there, but you take the science and put in your own personality and art into it, and when it goes well, it goes really well, and it's so rewarding to see, especially when kids find so much power in life in things that once terrified them.
Yeah, absolutely. Okay, so how does OCD differ, if it does, in children from how it may in adults?
So at its core, I don't know if it differs all that much. I think most of us know that there are age-specific and demographic-specific worries that kids and then teens and then adults have. There's not too many adults running around afraid of clowns and needles and things like that, though some adults might worry with that. So I think there are probably some topics that are a little bit more salient to kids versus adults. But in our practice here in Atlanta, we see kids who struggle with all the same, what I would describe as more traditionally understood OCD conditions, like contamination and perfectionism, checking kind of behaviors as adults do, and many of the more existential ones like harm OCD. We see a lot of religious and moral scrupulosity. So I think from a content standpoint, I don't see a lot of difference. From an exposure standpoint, of course, depending on the age of the child, there's much more work with the system. And I recall in the last podcast we did, I made a point, and I firmly believe this, that the next wave, the next generation of effective interventions for anxiety and for OCD is really working on the system, whether you're a child, teen, or adult, but specifically with kids. Any therapist who's working with kids and anxiety and kids with OCD has to be able to both developmentally work with the child wherever he or she is, but also work with the family and system around them, which typically involves some level of caregiver, whether it's a biological or adopted parent or a nanny or a grandparent, and then the school system. So from a treatment standpoint, you're doing a lot more systems-based work. From a education standpoint, you're educating the child, the identified patient, on a lot of the struggles that they're having and how to understand OCD and anxiety. But then you're also educating the caregivers and the parents about their own hangups, the struggles they have, and the anxiety that they might bring to the table, and maybe some of the things that they're doing and not doing that are helpful or unhelpful. So I think there's an approach that's different when working with kids, a little bit different than maybe, how is OCD different, which I don't think it's really that specifically different from other aged populations.
Yeah, good point. And what sort of ages are you working with in terms of I won't include teenagers in this, or adolescents, but just children. What sort of ages do you work from?
Sure. So specifically with OCD, we're seeing kids between the ages of 5 and, again, really up to age 18, but 5 to 12, 5 to so preteen. Our practice is not an age practice. So I think a lot of practices here in the U.S., when they see kids, generally, you're expected to probably be a more of a pediatric focused practice. But you come into our waiting room at almost any time of the day, and you can have a 3-year-old in there with selective mutism and a 70-year-old struggling with a first experience of panic disorder. So that's what I love about our team. It's a very unique experience to go as a therapist from working with a 3-year-old and his or her parents to then doing an intake on someone who has spent 70 years of his or her life, with minimal to no anxiety, and then having a first sort of anxious experience. It's a fun thing to do. It's a bit of a mind warp. But specifically with OCD, typically kids between the ages of 5 and 12, because though I think there are some interventions you can do specifically with a child under the age of 5, you really do need a child to be at that cognitive and verbal level to understand sort of symptoms and what worries are. And maybe we'll talk about worry monsters in a few minutes, but what those concepts are, how the brain and body are impacted by anxiety, the concepts of fear and obsessions, and ultimately getting to the point of rituals and safety behaviors. And I'm sure there are some 4 and 5 and 6-year-olds who have the linguistic and cognitive capacity to understand that and engage in treatment. But I think developmentally, that's probably the lowest end. I'm sure there are people that can work with 4 and 5-year-olds, but I'd be a bit reluctant to do so. And if you're doing that, you're probably working much more with the parents, educating them about the signs and symptoms and what reassurance is and family accommodations and some topics I venture we'll get into in a few minutes. But between the ages of 5 and 12, I think if anyone sat in our offices and watched our treatment, shy of probably using a little bit more humor and entertainment, and I do some magic tricks in my own office of getting kids to sort of be engaged with what therapy can be like. I think ERP for OCD and kid populations is really not much different than working with adolescents and adults.
Yeah, good point. Okay, so worry monsters. What are worry monsters, and how do you use them, and why do you use them?
Worry monsters. Worry monsters, at the end of the day, are simply a sort of a visual object that we talk about. I learned about worry monsters many years ago reading a lot of work by Tamar Chansky, who I am a big fan of. A lot of her books don't focus exclusively on ERP or exposure and response prevention methods, which is okay. I think there's a few different ways to address child anxieties. My whole team takes a very exposure-based practice, but there's other ways to help kids learn about emotion regulation. And so she's not the only one that talks about worry monsters. There's lots of people that do, but one of her books that I really swear by for clinicians, definitely parents maybe, a book titled Freeing Your Child from OCD, talks about worry monsters and how a therapist and the child and the family can talk about sort of this other family member that we're all the elephant in the room. And we have a child draw out on a piece of paper their worry monster, and we have them draw it out. We have them name it. And then we talk about how this worry monster is like a bully. And so many therapists who treat anxiety talk about bullies or bully monsters or worry monsters. And so one of my favorite parts about using worry monsters is it gives us as a system, me, the parents, and the kid, all something to rally against. And you'll see I think it's pretty common that a lot of kids who have anxiety will experience a lot of conflict in families for a bunch of reasons. And so when we start, rallying around the child and work together to fight against the worry monster, as opposed to fighting with the child about what he or she isn't doing or what they're not willing to do, or that they have to go back to the bathroom, or they won't go to that restaurant, or their paper has to be done a different way. And it's very easy for a parent, and talking both from personal and professional experience, to get easily frustrated and mad at your child for not doing what you think they should do. When you shift that power and that blame towards a different entity and you watch the power shift, it's a really empowering experience to watch the parent. And it looks absolutely goofy for the parent to say, is that Sammy, the sacrilegious worry monster, making you do that? Is that, Kendra, the kidnapping monster, attacking our family? When the child sees it, all of a sudden the parent is kind of seeing the worry the way the child is. And we literally have this piece of paper that I know people can't see what we're talking about, but I got volumes of worry monsters in my office that kids draw with some of the most fantastic names to represent what their worries are. And we all work together to fight against these worries and bully against them. It basically represents what the amygdala and the limbic system of the brain is doing, which a lot of kids can't fully appreciate. And it gives us some language and some tangible objects to work together and fight against. And as I tell kids at the end, once we've successfully graduated through exposure and response prevention, and they're fighting against a worry monster consistently and getting rewards for doing so with their parents, that worry monster lives with Dr. Josh. That worry monster lives in my office. And so it's a really neat day. It's a graduation moment for them to take their worry monster, and we don't shred it. They give it to me. It goes into my file of many other worry monsters that I show other kids so they understand what worry monsters are. And it gives a child it's a nice transition object, a way for them to sort of create distance. And then that worry monster can bother someone else. And most of the kids know that those worry monsters don't attack me or my other doctors here. And so when they're free from that, I think it's a really powerful moment. It sort of solidifies the next phase of what their maintenance phase of, I think, ERP is. And they can move on to, bigger and brighter things. And it's just a really neat way to demystify what's going on in their head and have the family work together on common ground.
Yeah, and it also strikes me as kind of an acceptance and commitment therapy thing of putting it down on paper gives you that distance from your thoughts instead of being your thoughts. Is that...
Agree completely. I probably wouldn't say that to a kid, and it's not what you're recommending, but in the ERP space, there is so much work about accepting and staying with and acknowledging. And even we go as far as with most patients, documenting not just your worries, but the most catastrophic versions of it. So for a child to draw on paper their own version of what this thing looks like in their head, very much an effective method in and of itself to get it out of them, get it in front of them. We all can kind of see what we're fighting against, and to be able to sort of concretize and put some real structure behind it. I think for the child and for the family, it's a very powerful moment. And yeah, acceptance is a good way to describe it. It's sort of for all of us trying to finally admit this is not a bad kid. This is not a strong-willed child, and they might be strong-willed. This is not a child who's trying to defy you or who wants to be stuck. No kid, teen, or adult wants to battle OCD. And so we can finally put some language and structure behind what it is that's attacking you, and accept it. I think it's a power shift in the family, and an important one that has to happen so the parents and the child work more together rather than apart, which again happens quite a bit when families come into our practice. And there's a little bit of finger pointing and blaming and making assumptions that the kid wants to do this or they have more power than they actually have. So both, I think there's an acceptance component to this, but also a real power shift, which a lot of CBT therapists I don't think talk about, but it's something that if you watch with kid therapy, it's a wonderful thing to see when parents and kids start working together rather than apart.
Yeah, really good point. And with the worry monsters, you said that they often leave it with you because at the end of treatment, because it's kind of you're protecting it or you're imprisoning the worry monster, so to speak. Did any of the kids ever want to do something almost like to screw it up and throw it in the bin? Or
Yeah,
Yeah.
lots of kids, first of all, when they draw, lots of kids want to scribble on it. So again, I'm
Okay.
working with kids that are as young as 5 and 6 whose art skills are maybe not the best. So imagine, and this is not terribly funny, but it has a layer of humor to it. Imagine working with a child who has a lot of perfectionism and doing that drawing out. And for some kids, when the drawing truly doesn't match their visual version of what they thought they were going to draw, they want to scribble it out. And that is the thing about an intervention within an intervention. You've had a child who is reluctant at times to write things down or draw things because it never is exactly what they want before even getting into treatment, putting something on paper, which is a sort of an element of finality, not liking it and wanting to start over. And if you do what I do, you don't let them start over. And that's a real trying moment in that. So whether it's from that perspective, which is more clinical, or yes, kids who want to shred it, kids who want to, we have a shredder here, or light it on fire, which I've had kids want to do, or simply just tear it up. I'm not opposed to that if they really want to. There's nothing special about doing that or not doing that. But I think there's power in letting it exist out there in sort of this uncertain space. If we talk about treating uncertainty, and let it sit in this uncertain space and really not make it go away, knowing that it's always there. It could always come back. But as long as Dr. Josh or your therapist has it, they're going to be a good protector of it. Again, it's another power shift of giving that worry monster and that problem to me, because I'm a big kid and I can handle it just fine. So I wouldn't be opposed for someone to get rid of it, but I like to keep it somewhat active and alive to know that it's sort of sitting there, and we'll see what happens.
Yeah. Yeah, I like that keeping it, keeping it in existence, because then it's there's always that possibility that the worry monster could come back, and they have to kind of live with that or wrestle with that uncertainty.
What a tough concept, Stuart, to teach a kid, 5, 6, 7-year-old that, we talk about other kind of boo-boos and medical things that hopefully when your strep goes away or when your broken ankle goes away, when it's fixed, it's healed. But in the space of mental health in general, and I think most of us who treat anxiety and OCD believe that there's no cure. Many people go asymptomatic, sometimes accidentally, and sometimes through a lot of active treatment or medication treatment. But the concept that it could come back is a terrifying concept. It's not one that I like to think about, but it's a lifelong illness for many people. And so I think it would be naive to think that just because, we got over this moment and that the worry monster is done, that you're done with it. That's never anything that I teach families. In fact, maintenance is a major component of any kind of treatment. And so, it hits the elements of finality. I don't want to empower someone to think about things are absolute too much, uncertainty, but to encourage a child to think about that, not that I want them to think that this could come back, but that they need to stay vigilant and active with all the amazing things they've done to get here. And that if it does come back, we can pull it right back out of the drawer and come back to where we were. And sometimes you'll have kids draw multiple versions of a worry monster. Again, that gets a little bit too deep into the content versus the concept. So I like to try and draw one worry monster to address all of the worries they're battling. But some kids feel like, every worry needs to have a specific drawing, and that can be, 1 or 2 sessions of time spent. But usually I don't like to promote that every problem is a monster. That's a lot to take on.
Yeah, good point. Okay, cool. So you did talk earlier about ERP, specifically with children. But yeah, what does it look like, or how does it differ from that with an adult when you're actually doing the exposures and the response prevention in a session?
Sure. So I think the first step, and really I probably should have introduced this at the beginning, is if you're working with kids, you work with families. The Academy of the American Academy of Pediatrics is undeniable about this. The research is undeniable. And there's also interventions going on, great interventions right now about really addressing either the anxious parent or the parent involved in anxiety treatment with kids. So I think I would step back just a second and highlight that any work I'm doing with kids is undeniable, especially the 5 to 12-year-olds. If we remove the teens and young adults, which I think for the purposes of this discussion today is maybe helpful, I couldn't conceive of working with a child and not working with at least one primary caregiver. So ERP is significantly different because before I even get to ERP, I'm doing a lot of parent-based education work about family accommodations, which is just a fancy phrase for the things that they do that they probably think they need to do or they think that they have to do to keep the house and the family civil, to reduce the child's anxiety, to keep things as safe and calm as possible, when in fact, though I appreciate that the short-term gain is significant, the long-term gain is that you're teaching a child that mom and dad will save the day or make significant accommodations and changes so everyone feels better. And That's not the approach that we take with treating the anxious child, no matter what the diagnosis is in general. And so ERP with kids really starts with a parent perspective, which is how do we help the caregivers, A, learn about what anxiety looks like, B, do they bring any anxiety or previous history of child anxiety in their own upbringing to the table? See, what kind of parents are they? Are they more authoritative, more authoritarian? Are they more permissive? D, E, and F. What are the parents doing to unintentionally enable some of the safety behaviors and rituals that are going on? Because if my focus with working with a child is to teach them traditional exposure and response prevention, it's impossible to do if the system itself is sort of enabling this process. And so I sure as heck wouldn't want to work with an alcoholic who's sitting in a home with bottles of booze or beer everywhere. That seems very sort of contraindicated. And so in this context, it would be very limiting for me to teach a child ERP, exposure and response prevention, if the people around them are also doing what I would describe as almost really secondary rituals, which is enabling some of the needs that the child thinks that they have, and the parent stepping into, from an anxiety perspective, save the day. So ERP starts with a lot of education, but that's probably true with any OCD family or individual you're working with. It involves making sure that the parents are actively involved in what they believe are rituals that they're doing to save the day. And then eventually start talking about a family-based plan where parents are removing a lot of reassurance giving or reassurance offering, often in the form of kids asking lots of questions. I like to talk about the W's, the who, what, where, when, how, why, and how, which ends in a W, I know. But those kind of questions are notoriously coming from kids and asking a million questions a day. And though it's so tempting to answer, teaching parents how not to answer that, also how not to not answer it, and then finding some medium ground of answering it with a level of uncertainty that leaves the child a bit uncomfortable. So I'm starting with interventions before I even do ERP with teaching parents how to basically neutralize, not to neutralize anxiety and keep anxiety between them and the child, while also not trying to exacerbate conflict. So that to me is the first level of intervention before we even get to ERP with kids.
Okay, and do you work with the parents before you see the kid, or do you see the kid, then take a break, work with the parents for a couple of sessions, and then start treatment with it? How do you kind of, divvy that up?
Yep. Great question. And I think each probably practitioner and clinic has their own approach. I generally meet with parents and kid right away. As someone who is a specialist in treating selective mutism, especially with the younger kids, we almost always meet with the parents by themselves first to really understand the nuances of what selective mutism or SM is doing, all the different ways it's impacting them, and then teaching parents very targeted and specific skills that are based in parent-child interactive therapy skills. When I'm working with OCD, kids with OCD, in the spectrum, health anxiety, OCD, and those kind of conditions, I personally have the kid and parents together. I know a lot of clinicians probably would argue against that because you really want to understand the parent's perspective, work with the parents, educate them, and I fully appreciate that, respect that, and I don't believe the science is far enough for us to know whether one is better versus the other. But I love bringing parents and kids together right away. Maybe it's more of my style, definitely part of my training, but I want to see that parent-child interaction right away in the room. Obviously, I'm not looking to do too much to surprise or scare the child. With some degree of variability, I might do some of that because I want to see their reaction. But I'm interested to see right away how the parent and child are interacting, what things in the room are what I would describe as almost these micro rituals or these tiny things that parents are doing in the moment to enable or answer questions before they should. If the child's super young, if we're talking about the 3, 4, 5s, I might be more inclined to do an intake with just the parents really to understand what's going on because it might not be an appropriate referral. The child might not be that verbal. I definitely don't want to do anything that's going to create too much anxiety in the child. But if I'm working with 6, 7, 8, 9-year-olds and I see this intake that's rich with information about, we've probably been to a few therapists that haven't worked out, or we learned a lot about your practice, and people don't find us accidentally because we are such a specialty niche anxiety group who does a lot of exposure therapy. People don't find us accidentally. Parents and kids are kind of ready to come see us, even if they don't want to do the treatment. And so I'm much less worried about having someone come in and feeling a bit overwhelmed. But I think that hopefully addresses your question, which I'm more likely to bring parent and child together right away and do a lot of education, both to parent and child in that first session, because I want to excite the child right away about what treatment can look like. I want to empower and validate the parent's fears and concerns, both as a parent who has an anxious child, but also knowing that parents are coming in probably with a lot of shame, a lot of frustration, a lot of fears and concerns, a lot of wondering about how this therapy could be different than anything else. And I want everyone in the room at the same time to have that same level of, oh, okay, you understand us and you know what's going on and you get how difficult this is, and that we do have often this identified child and we feel paralyzed. And I think it's, again, from a power perspective, a very powerful thing for all of us to admit that things may be not going that well. And if we work together and find a new way to do something that we've been doing all along, that a lot of things can change. And to watch parent and child at the same moment sort of have that relief that they're not an anomaly and that there are plenty of families and kids who struggle this way. I like seeing that little paradigm shift. And I think that's just a really neat thing to experience. But I appreciate that some clinicians would be reluctant to do that right away with kids and not wanting to overwhelm them and really want to learn more about the family and the family dynamics. I like to get in right away and not waste too much time and go right after it.
Yeah. Cool. No, thank you for describing that. And then when you're setting up ERP with the child, how do you talk about that? How do you introduce it as a concept?
So I'm going to reference the movie Unstuck. Easily the greatest movie. I've only met Chris Bear and his family a few times at conferences, but anyone out there who has little to no exposure to pediatric OCD and either wants to learn about it as a clinician or more for people who are personally affected by it. And again, this is really, I know this specific podcast we're doing today, Stu, is about OCD. Really, someone who has any child with severe anxiety should watch that movie. And there's many ways to access it. The movie's called Unstuck, a pediatric OCD kids movie. An amazing movie filled with lots of scenarios of vignettes of real kids who have really battled OCD with really great ERP from, I think, some of the best clinicians around. But if you do ERP, in my opinion, is you're doing the best work out there. I think using that information, seeing those kind of videos, learning about that kind of stuff's empowering. And there's a clip in there where I believe it's Vanessa Bayer, who so articulately and so poised talked about how exposures are like a challenge. And she said it with just this innocence and this brilliance. And I don't know if it was scripted or not. She is a lovely little girl and young woman who has been such an important advocate for what ERP is and OCD, pediatric OCD is. But when she said that, I've shown that 5-second clip hundreds of times in my practice. And to me, any kid gets that concept, that exposure and ERP, it's a challenge. And if you understand that that's what it is, it doesn't have to be any more magical or scary than that. It's a challenge. And if you can fight that challenge and do things that feel a little bit uncomfortable, things you've already been doing without me, before you ever met me, for most kids who have OCD, every day is a challenge and every day is uncomfortable. But this kind of challenge and this kind of discomfort gets you to a place of feeling more empowered and more in control and finding real solutions for real scary problems. It doesn't require sophisticated clinical language to help a child understand that there are some very basic ways to go towards fear, even though our body wants to go away from fear. And that if you can do that, you can be powerful and you can be in control of moments for you feeling out of control. A very basic metaphor I use all the time is if you're at the park and you're by yourself, for whatever reason, which would not be a good idea for a kid, your parents are a few steps away and you see a scary dog at the park, this dog with big scary teeth, growling, and they're off leash. And I'd say, in that moment, little kid, what would you do? Stu, I think any of us would probably say, run. And unfortunately, first of all, I hope that situation never happens, but I can guarantee you, unless it's a little, Chihuahua or teacup terrier, most of us, including you and I, are never going to outrun a dog at a park off leash. And so our natural instinct is to run away from that feared object. But the reality is not that I want a child to get mauled, but you stand there in that moment, face that fear down, and obviously I'd call for help and I'd try and defend myself, but that's probably your best chance in that moment when that feared object is coming towards you. The good thing is with OCD, with about 98% of the kids that we see, there's no real identified feared thing that's actually happened. So I'm sure there's a co-occurrence of traumatic experiences that have led to OCD. But for I'd say the majority, I'm talking 98 to 99% of the kids that we see of all anxiety disorders, nothing bad's actually happened yet. And I'm banking on that. That's not always the case. And so when I say that when I use that metaphor, we're talking about these concepts of fear that kids and teens are afraid of that haven't actually happened, thank goodness. And I'm talking about real catastrophic outcomes. And if you can face that down and not run away and stay with it and go towards it, that's the challenge. And if you can face that challenge with your family who's supporting you and a therapist who's done this with other kids, you too can beat that worry monster, beat that challenge. And when that happens over and over with lots of practice, which is what ERP is eventually going to be at home and at school and with your friends and at play dates, then you are now the boss of your worries and nothing can take you down anymore. You didn't hear me use any sophisticated language. And I might not use that much sophisticated language with adults, but you don't have to get overcomplicated or technical. Kids get that things are scary and they haven't died yet. And I don't plan on them dying. And I emphasize the concept of scary safe versus scary dangerous. I don't do scary dangerous, Stu. I don't think you do either.
No.
I do lots of scary safe. Yeah. So we do lots of scary safe in our practice, meaning that things that feel scary but are designed to be predictable and safe. And that's what OCD is all about. It tricks your mind into thinking that things that feel scary must be dangerous. And thank goodness, most of the kids that I treat haven't dealt with danger in their life. And I'm banking on that and playing on that, knowing that as long as we keep doing things that have a sense of scary, but you're still in a safe environment, that we can beat those things. And that's what an exposure is, and done very delicately and very patiently, with the kid being able to say yes and no to things they do and don't want to do, with a therapist who's not going to put them in dangerous situations to the best of my ability, and watching them succeed and thrive and be empowered, which is such an awesome thing to watch. And you asked me at the beginning, how is this different than working with adults? And I love working with adults, especially adults who haven't had good ERP. But when you watch a child's eyes light up and they really figure out the math and science behind exposures, the whole house of cards, which is a big fat lie, falls apart, and it's awesome to watch.
Yeah, no, that's great. Thank you for that breakdown. And then a key part of obviously ERP is or any part of CBT is the homework.
Yep.
There's only so much you can do in that hour or 45-minute session each week, and the rest needs to be done at home or at school or wherever. How do you get, especially the real younger children, obviously it's working with the family system, but how do you get them to adhere to homework and put in the work between sessions?
I just tell them to do it and they do it. No, just kidding.
Yeah.
Oh, if it was only that easy. Yeah, never. Rewards. I think that any intervention, obviously adult and teens, I wouldn't even argue against this either, but any intervention where you're asking a child to do something that feels at times impossible or counterintuitive should have a paired component of it with enjoyment and excitement and rewards. And for some kids, rewards are a 1-to-1 ratio. If I do this, I then get immediate candy, movie theater, an app that's free, or a song on my iPhone or something like that. Some rewards are much more like gamification in apps where, you get a sticker or a cotton ball or some sort of check off, and after 3 or 4, then you get a reward. So that reinforcement schedule can differ for child's intellectual and kind of cognitive abilities. But almost every intervention I do for kids with anxiety has a rewards component to it, at least at the beginning. And so that they're hopefully as incentivized as possible. Plus, it's way more fun for the parents. For the parents to watch a child get excited about doing something, because there is both the reward of the anxiety and the discomfort possibly going away over time, which is much more of a long-term play, but that they do get, more screen time. Oh my God, I said it, more screen time, or dessert if they didn't earn it because they didn't eat their dinner, or extra snuggle time in bed, or a scavenger hunt at home, or going to a $5 store and buying some sort of little tchotchke or toy, or getting that drink that they never get at the restaurant. Most kids like that stuff. And so my kids are no different. And so any intervention that asks a child to do something that they think is, climbing to the top of Kathmandu or some gigantic mountain, I think it's a powerful thing to do. It's fun. It gives your child a chance to sort of manipulate you and the parents by coming up with this elaborate reward system, which, manipulation in session is always a fun thing, especially when the kids think that they're beating us and winning. So obviously having a rewards based and having a lot of fun with it, having some games associated with it, I think are the best ways to do any ERP. It's unrealistic for a child who most of the kids we see, and I can go as far as saying most of the anxious kids we see in our practice, Stuart, are pretty intellectual kids. And we see some kids who maybe are not in that space, but most of the kids who have some of the most elaborate existential worries that they have, these are not dumb kids that we're seeing here. And so they're smarty pantses, and they're highly motivated by puzzles and math and thinking and linguistics and words. And I love that. And so we use that to our advantage and create some elaborate fun games and activities based on that. But you're also working with kids that are very determined and strong-willed and don't like to lose. So again, manipulation in therapy is not a bad concept if you're helping people. And so finding some gamification or rewards-based program that gets the kids to strive to beat the system is fun. And one of my favorite lines is the parents say, but what if they get all these rewards? Or what if they break the system and, cheat the system and get so many rewards? My response is, you're welcome. Because what you just told me was your kids are finding ways to reduce rituals and compulsions, ritual prevention, and do these exposures that most humans would not want to do. You're telling me that you're concerned that your kids are going to get overly rewarded for doing the exact thing that's going to help them have the life that they want? You're welcome. And so I love doing interventions with kids for which they help us design the most fun, elaborate, game-based exposure and response prevention activities. Having said that, that's sort of the overarching idea, but ultimately you need parents' buy-in. There is no chance of a kid doing these interventions if the parents are either accidentally or intentionally doing accommodations or rituals at home, or the parents are using a lot of expressed emotion or conflict at home when the children are struggling, or if you have a 2-parent or 3-parent system, where if there's not a lot of excitement and enthusiasm with the interventions, you're not going to get a lot of adherence with the kids. So again, this comes back to the very beginning of making sure your parents are completely bought into what we're working on. They're getting parents hopefully using the same level of tenor and emotionality and patience and civility and kindness. And doing so with a reward system, I think, is probably for me one of the most foolproof methods. And still, sometimes kids don't do their assignments, and sometimes they do them at the last second. I always love to see when kids give me like their sheet of paper, and the handwriting looks absolutely identical across the entire sheet of paper with the exact same pen, written at the exact same angle. And my first question is, did you do this in the car riding over here today? And, it's just a funny moment because most kids do that at some point in therapy. And it's just a reminder of they're kids. They have homework with school. They have homework with violin. They have homework with soccer. And we're just one more thing giving them homework in our lives. But hopefully you can find a way to make it fun, make it rewards based, have the family have fun with it. If there's siblings involved, you did an awesome podcast a few episodes ago about involving the sibling and OCD treatment. I think it's absolutely crucial. It's why the system is absolutely fundamentally important in doing this. And so if there are identified family members who are either resisting this or getting in the way, that's going to be one of those TIBs, one of those treatment interfering behaviors. And so this is why, the work with kids is a little bit more complex than just working with an adult. You have to have that level of systems approach. But rewards. Parents out there, please do not be afraid of rewarding your children for being compliant in therapy. It's way more fun.
Yeah, I like that. Thank you, and for the illustration too. Something that I don't think I may have been mentioned in passing, but I've never asked a question on it, which is Pandas. So, kind of, what is that? And just anything else worth sharing on it?
Absolutely. So, for anyone who doesn't know much about Pandas, and there's really 3 different acronyms you're referring to: Pandas, PITANS, P-I-T-A-N-D-S, and PANS. They're a little bit different, but at the end of the day, what we're talking about is an acronym. Pandas stands for Pediatric Autoimmune Neuropsychiatric Disease associated with streptococcal infection. A lot of words. All it means is that there is an underlying medical condition that at its core is either the cause of an acute onset of OCD-like symptoms or exacerbating an already existing OCD-like condition. And this really came about back in the late 90s. Dr. Susan Sweeto at the National Institute of Mental Health and her team really first coined the phrase. And then a few years later, in the early 2000s, her and her team really came up with some of the most updated guidelines. And there's a great network out there, and people can search them out. The Pandas Physicians Network. I think there's even a website, pandasphysiciansnetwork.org or something close to that. That really talks about the most well-documented guidelines and the symptoms to look for. But just as a sort of, I guess, a cautionary note here, there are many physicians and people in the field of psychiatry who are skeptical that Pandas is a real condition. I'm not going to discuss the controversy around that, but as someone who I believe I'm a Pandas provider, I have Pandas in my office in here. I have Pandas as rewards I give to kids. I live in a world where I have seen kids who have gone from zero OCD to some of the most severe onsets within a day or two of getting a strep infection, having a tick bite that then transmits Lyme disease. And I've seen kids who have had OCD that was sort of simmering and with a set of chronic illnesses, looked borderline psychotic. Do I know if Pandas is the right acronym? If it's not a strep-based infection, then it moves to something called PANS, which is more of a syndrome, a pediatric autoneuropsychiatric syndrome. So the Pandas is much more about streptococcal infection. Do I believe that Pandas, PATANS, or PANS, the name is accurate, the pathway of this disease is accurate? I'm not a medical provider, and it's above my pay grade to know that, but it is undeniable in my clinical practice, in my team here, that we see kids and teens, and I've seen some young adults in the age of 22 to 23 who have an immediate onset following a pretty severe round of medical illnesses. And the research and the science behind it is that the part of the brain that is affected by OCD, that the emotional center of the brain, Stuart, the amygdala, the limbic region, which houses the emotional center, is sitting just around the basal ganglia, another part of the brain. And that basal ganglia, filled with ganglion cells, somehow gets exacerbated or assaulted medically. And the exacerbation of those cells interacting with the amygdala and the production of serotonin and dopamine and norepinephrine and all the neurochemicals that create psychiatric conditions, they sort of come together and it's a perfect storm. So I think there's many years of research to come to understand really the process and the illnesses that are most likely to contribute to what looks like a Pandas-like condition. But there are really good guidelines out there, and the International OCD Foundation has a lot of good research and documented stuff on there about the symptoms about Pandas. The Physicians Network I referred to has information out there. The National Institute of Mental Health has information out there. But I'd encourage any parent of a child who has what looks like an acute onset of OCD, an acute onset of school refusal, an acute onset of significant stomach and gastro-like complaints, an acute onset of what looks like ADHD or executive functioning issues. I'm not talking weeks and months. I'm talking almost within a 24 to 48 hour window, maybe within the first few days. An acute onset of handwriting that looks like it's gone from what looks like pretty healthy and normal handwriting to a complete decline of handwriting. And I'm sort of just spouting off the criteria of what Pandas kind of looks like. If you as a parent have a child who you believe has battled many has had bouts of strep, who possibly has had a tick bite, or who's had an immediate onset of what looks like anxiety symptoms, I'd encourage you to talk to your pediatrician about this. Not all pediatricians are even up on the research about Pandas and related conditions. And some pediatricians I work with here in Atlanta are completely anti even discussing with me. And I'm not a medical provider, and I can only encourage parents, if they believe that their child is struggling with a medically induced psychiatric condition, to find a healthcare provider who they believe at least can talk to them about it and who can direct them to medical providers who can follow the protocol, which includes both testing for strep. And before I even got in the space, I didn't know there's even stuff beyond oral. There's oral strep, there's anal strep, there's other versions of strep and other medical conditions that are sometimes hard to identify. There are blood draws that can test different levels, tighter levels in the blood. And so there are medical procedures that providers and labs can run to determine if there are elevated medical conditions. From a psychiatric standpoint, it's my job to empower the parents to get information, to get educated, to work with a healthcare provider that they believe can support them in getting the appropriate lab work. If there is an identified medical condition, I'm going to encourage them to get proper treatment, which often includes at the beginning an oral dose of antibiotics. And if that doesn't work, sometimes a more higher dose. And if that doesn't work, sometimes an elevated level of treatment called IVIG, intravenous immunoglobulin, almost a blood transfusion kind of thing to address the antibodies in the blood. And that's going to sometimes be paired with an SSRI, which is a medication for anxiety. And in my case, then traditional ERP. And so currently, right now, as we're speaking, I'm seeing 3 Pandas kids, 2 of which are at the tail end of what I think is the medical disease course and who have done an amazing job, both going through really difficult medical interventions and then following with parents what I describe as traditional ERP. And then with one case, not really doing ERP, but following Tamar Chansky's approach of being able to describe the emotional outbursts identifying what your worry monsters are, with the parents working on isolating those moments, coming up with tried and true interventions for emotional dysregulation and OC-like moments. And if that goes well, reward them. And I'm seeing a new family right now that I think is in the throes of a pretty severe medical phase of Pandas, and for which, Stuart, I am right now somewhat disabled. I mean, I can't do much when the child is so medically in disrepair. They can't go to school. They're having a hard time keeping medicine down. And so I'm supporting the family. I'm trying to get them to the right healthcare providers, and getting them to the right research groups that are doing this work. And I'm supporting the parents. And if at some point the patient is much more stable and able to sort of sit in my office for an hour, we'll talk about some emotional regulation skills. But right now, I'm just helping the parents try and find the right information and the right providers that can support them.
Yeah, no, thank you for that. It was useful. And I'm going to simplify it just so I can get my head around it. With OCD that's been, quote unquote, caused by pandas, you firstly medically treat the strep, which is with antibiotics. And then
strep or underlying medical condition.
So you'd have a medical intervention for that. Then you'd come in and work specifically with the ERP work, CBT work. Is there ever a case where the medical treatment effectively takes the OCD away in these cases? Or is it always the behavior's now been learned and you need to use a behavioral intervention to work that?
I love the question. You're asking this chicken and egg question, and I think the answer to my question is unfortunately going to maybe upset some people who are champions and supporters of what Pandas means. I don't want to, but the answer has the dilemma, which is for some kids, when the medical condition and everyone's belief is fully remitted and OCD is still around, is that really Pandas? And unfortunately, I don't have the answer to that. And I think I could equate that to someone who's been diagnosed with cancer who has a new onset of depression, and the cancer has been fully treated and they're in remission. They're still struggling with depression or anxiety for which they've never had. Does that mean that they had it all along? It's the chicken and egg. It's which biological thing was sitting there first. And I don't know, but I can tell you from my own personal professional experience and from having read enough papers on Pandas, absolutely, medical can go away and OCD can still be around. And medical can remit and OCD can completely disappear. And I just saw a family yesterday at another event for a kid who I saw several years ago, one of the first Pandas cases I saw, and I knew very little about it back then, who today is completely asymptomatic with regard to medical issues and who still has moments of anxiety, less OCD, but other kind of anxiety. But none of the stuff I saw for back then is current today. And so to me, that's one of those cases where when medical remits, the obvious psychiatric issues I was seeing remitted, but there's other things going on. And so for all you and I know, this is a case, not this child, but the Pandas concept is a case where there are these underlying neuropsychiatric conditions that are just sort of this vestibule waiting to erupt. In the clinical world in graduate school, I know you're training as a clinician. We talk about the diathesis stress model or the vulnerability stress model. You need that right diathesis, that right vulnerable thing, which whether that's the parenting or genetics or some biological agent, that right thing, that stress component. With that person who has that vulnerability or that diathesis. So maybe they have a genetic underlying condition. Maybe there's some other thing that's sort of sitting there. But with that right stress, that right moment, all of a sudden the disease that's dormant erupts. Maybe that's what's going on here. I don't know. But I do know that I see families, and here in Atlanta, there's a big initiative to get a Pandas clinic set up with a well-known child healthcare system here in Atlanta. I've been asked to sort of get involved and provide some at least clinical observations and guidance. But I do a lot of, consulting and advisement to families in this space. I don't see them all treatment-wise, but I try and connect them with really good therapists and medical teams. And in some circumstances, when the medical condition's gone, it's like they never had the condition. There's no OCD symptoms. And that's fascinating to me. And that makes me think that really it was much more of a medically based condition, truly much more of a neuropsychiatric condition. And there just happened to be what looked like tic-like behaviors and food refusal. We see a lot of ARFID, food refusal behaviors, a lot of school refusal, tummy issues. But when medical's gone, the symptoms remit, all symptoms. My experience more often is that when the symptoms are gone, there's still some underlying emotional dysregulation, some OCD tendencies, and some anxiety. So I've seen both sides, but I think that brings a bigger question, which is maybe there's a hybrid of what Pandas conditions are out there, some for which the child has no historical anxiety symptoms, Pandas starts, OCD starts, Pandas goes away, OCD goes away. And for some kids, they sort of have this underlying or undercurrent of anxiety, but with that right medical syndrome, all of a sudden you're seeing the kids in what almost looks like a hospital level of OCD. And my hunch is when that medical condition remits, there's probably going to be sort of a lingering effect of anxiety and OCD kind of symptoms. And so, medical intervention is first. Parent support is definitely second. Connecting parents with other parents who are Pandas parents or kids who have Pandas, I think is an important thing. So connecting parents with other support groups, which I'm able to do here in Atlanta because fortunately or unfortunately, I know lots of families who have experienced this, has been a big empowering component. So I'd encourage any clinicians around the country who work with kids with Pandas to try and connect parents to other parents, because I think that sense of community is a very supportive thing. But ultimately, for certain kids, I do more emotion regulation support. And for certain kids, I've got to do exposures if they're refusing school, refusing food, washing their hands excessively, not putting food down. And with certain kids who have a lot of executive function impairments, you'll see kids whose handwriting declines, who all of a sudden have attention or reading and writing issues. I want to hook them up with either a speech language pathologist or an executive function coach to get that back to where its normal operating level was. So it really depends on what problems they're struggling with.
Yeah, no, that's fascinating. Thank you for going into that. And it's definitely a topic I need to investigate further on the show. Yeah, but hopefully that helped many parents listening. Yeah. Okay, so next question, we've kind of answered that. Yeah, I've got two. You've kind of answered both of these, but I'll kind of merge them anyway, just in case there's anything else, which is, the one was, how do you work with families and parents of kids with OCD? And you have answered that. And the other one was, what are the key things parents and families need to consider when supporting their child with OCD? Is there anything else around those two that you could add to?
Yes, there is. And so I didn't mean to sort of circumvent the question you had earlier about how do you do ERP? I don't want to. You've had such amazing podcasts with such really amazing researchers, clinicians, and OCD sufferers, some of which are now champions and advocates in the field. I think it would be I don't need to go into I hope I don't need to go into what ERP is. And I don't believe the exposures are that significantly different. Again, in our practice, we see kids who have a lot of perfectionism OCD. Again, we're dealing with school age people here. So perfectionism OCD. We see a lot of moral and religious scrupulosity. We see a lot of kids with harm OCD, a lot of checking for break-ins and kidnappings and kind of things. There's a tricky thing of, is this separation anxiety versus like fear of your parents dying? What's the difference between separation anxiety and harm OCD with parents? And there are some subtleties of those. We didn't really talk a lot about that stuff, but this podcast for me, I think is so much more about parent engagement and parent support. I do want to make sure that we do talk about some of the things I'd want parents to consider. One of the first is, and I came up with this line. I'm sure it's not a special line. I'm sure I'm not the first and last person to say it, but I love parents hearing that you're not the problem, you're the solution. Mm-hmm. And I firmly believe that because, Stuart, I'm a really thoughtful dad. I have messed up probably more times than I've done right in my whole life as a parent. Michael Jordan's missed more shots than he's made, so I'm in good company. But there's moments when you're working with your anxious child where you really think, God, what the heck am I doing? Am I creating this problem? And that's a natural reaction for any person who loves someone with OCD, whether this is an adult to another adult or a parent to a child. But I want to stress that parents, there are good books out there, and I can tell you some of them at the end. But there's not a real good guidebook when you have your baby and he or she starts developing these worry symptoms and separation moments, and like, what the heck do you do? Because you just want the pain and the tears and the fears. You just want them to go away. And for some kids this erupts, and for some kids it doesn't. And I have one child who doesn't have that kind of fear, and one child that does, which makes my wife look and I and go, okay, so maybe we haven't, broken both of our kids yet. But I need parents to hear that, pay attention to your child's feelings, be able to describe them and validate them. I think that's such an empowering thing to do, to be able to describe to your child what you see is going on without much judgment, without much interpretation. I think any person who's struggling would love to hear that I'm being seen, I'm being heard. I think that's important. I think teaching parents, this is a real tricky one, to discuss why worrying is a good thing with your children, which seems so counterintuitive as I see parents go, oh, just tell them everything's going to be okay. And you and I both know, working with OCD, that's not the line we use. That's reassurance giving. Or just take a big, deep breath, which every parent has done. We've probably done it to ourselves. And honestly, when you take a big deep breath when you're panicking, guess what's going to happen? You're going to panic more. So you're activating your sympathetic parasympathetic system. So talking with the family about worrying is a good thing, and worrying is there for a reason. Unfortunately, that brain goes into the switch mode and it overinterprets, danger versus not danger. Teaching kids to live with uncertainty is an important thing. Obviously, most of the work we do with parents is trying to avoid excessive reassurance and modifying expectations during those real stressful moments, and really working hard, especially if there's multiple parents in the home, to be a team and to support each other. If one parent is struggling to give in, to be a very loving parent, but the parent that's more likely to give into those moments, and for parents to be aware of how your own anxiety in those moments makes you a vulnerable target, because kids are awesome at splitting parents. It's what they were designed to do, to pit them against each other, to pick the good cop and the bad cop, and parents know which one of us usually is that person. And so I think that team approach, if there's more than one parent or caregiver in this process, is a good thing. Something I also teach parents is be ready for conflict. I'll tell you, Stuart, of all the books I can recommend out there, I don't see conflict as a major theme in a lot of the pediatric OCD books, but conflict is absolutely a ubiquitous concept that every family comes in and says, my child at times is unbearable. It's impossible. They ruined our weekend. This is terrible. And I know what they're saying, and this is the moment where you then have to validate the parent and say, hopefully this is not being said in front of the child. But conflict is such a neat concept in anxiety. And this could be, if we're talking about adults with relationship OCD or any teen or child, but with children, conflict is a beautiful, elegant, manipulative monster in the home. Why? Because conflict always ends. It doesn't end good and bad all the time. Sometimes it ends with an apology or tears. Sometimes we don't know if someone accepted our apology. So it doesn't always mean that the end has perfect certainty. But conflict has a beginning, middle, and an end. And we all know when that moment is past. We might be holding a grudge. We might be gritting our teeth. We might be, brooding or stomping around the house. But when that moment's done, the moment's done. Like a perfect scab being picked. The conflict is over. And so I find conflict to be this very funny, manipulative concept with kids with anxiety, because boy, do they and their worry monsters know how to bring that into the home. And even if it messes things up, at the end, there's always sort of that sunset. And for anyone who has anxiety or OCD, that sign of that final moment, it kind of feels good. It's kind of the ultimate ritual. It's the perfect certainty. It's the perfect, we're done. And so I tell parents to be ready for conflict. It's a ruse. It's manipulative. It's not your child. It's anxiety. It's uncertainty. It's unpredictability. It's trying to get some guarantee of, please accept my apology. Please make everything okay. And so to not, punish your child in that moment is a really difficult thing to do. So punishment for the anxious child is probably one of the worst things I think a parent can do, shy of being neglectful or hurtful. Punishment gets you nowhere because your child's anxiety is going to fight back. So getting to know your vulnerabilities and your own worries and your own stresses, and seeing how your child reacts to stress and anxiety, and not falling victim to the ruse of conflict, is such a difficult thing to do. And something that my wife and I joke about, but I've taught a lot of parents, is find the funniest. I'm giving away a little secret right now, so hopefully no, I'm not giving away too many gems here, but find the funniest, most ridiculous thing you can do in the house to take back the power. I've used the theme power in this podcast a lot. Things like you accidentally twist your ankle and you need your child to come get a bag of ice and save the day. The toilet accidentally got flooded or stuck, and you need the child to go get you a plunger. Or that dish in the kitchen that fell and that spilled stuff everywhere before the dog comes in and licks up all the spaghetti. Quick, go get me paper towels before the dog eats the spaghetti and gets and has diarrhea. So you all of a sudden take this moment where there's conflict around OCD and anxiety in the home, and you, the parent, get in the victim role and create this moment where only the child can save the day. And hopefully, I don't give this away to too many kids, but it is one of the funniest things to watch a parent go to this silly, goofy place where they come up with the most elaborate ruse in the home to become the sort of powerless. And this is not in any books that I've read, and I just came up with this on a whim, and it's such a wild intervention to do. But to have the parent need the child after minutes, if not hours of conflict, and have the child come in and swoop in and save the day and think that they have fixed the whole problem, and all of a sudden the moment passes. Stuart, I haven't written about it. I haven't found it in too many books. It's one of the funniest things to watch a child get manipulated by their own parents' manipulation. Doesn't work all the time. The kid sometimes picks up on it, but it's one of the neatest things to do because it's a power shift. And when someone's in an anxious state and they're freaking out and really angry and getting in sort of that stuck moment, it gets them out of that stuck moment. I love doing that. So it's just one of the things I like to teach parents, which is find some gimmick, find some ruse, do something to shift the dynamic in the house, and all of a sudden have the child save the day and watch that moment fall apart. Is it distraction? Sure. Is it a bit of avoidance? Maybe. But sometimes when parents are in that jam and they need some moment, you got to do it. And yeah, I'm not sure how often you should do it, but I find it to be a funny and manipulative intervention to fight back, not your child, but their worry monster. So I think the final thing I'd recommend for parents is compassion, self-compassion. Take care of yourselves. Being a parent of an anxious child is the hardest job I've ever had. It makes me love my daughter that much more. She is the most amazing, beautiful thing in the world. I am so proud of her. I'm more proud of her in these moments where she defies her anxiety than the moments that are easy for her. I think any parent could say that about their child. So, but I see that moment and I see that struggle. But sometimes my wife and I forget how hard we've worked to get here. And again, we mess up plenty, just like every other good parent out there. But to support each other as parents, to love each other, to be kind to each other, to acknowledge that, gosh, God, I messed up, but you did a great job in that moment. She's like, oh, no, you did it. To be able to support each other, it's a real powerful thing. But self-compassion to yourself, compassion to your loved one, your partner, if you have that opportunity to have another parent doing this with you, it's crucial because the bad days are bad. I know that. And the good days are absolutely beautiful and empowering and lovely. And most of us want to have more good days than bad days. So being kind to your child in these tough moments is hard. Being kind to your partner and yourself is super hard. And I think doing that supersedes every intervention out there because, those tough moments are tough. But there is a solution. ERP is effective. There's some great resources out there. And don't give up because, there's some people out there fighting for you.
Yeah, thank you. That was great. And I guess I'll ask this for both you as the therapist and also the parents, but how do you keep a child's spirits up during treatment?
How do you keep your child's spirits up during treatment? Well, I fortunately have enough reference points so as a therapist, I have enough reference points in my own career where I can share with other kids I've worked with. I have parents actually sometimes contact other parents who are in similar struggles. I am right now about to put on for my team here, a town hall, a parent of anxious child town hall. So parents of similar experiences can come together and support each other. A free event. I'm looking forward to doing that. And if, depending on its growth and size, maybe doing something on a larger scale, but probably starting with a lower scale of 30 to 40 parents coming together and just sort of having a big Q&A to understand that you're not alone. But in the course of treatment, it's why I find CBT to be a very important homework-based and document-based thing, is documenting those milestones, being able to have the child, verbally talk back to that and fight back that worry monster, watching the rewards come in. One of my favorite sessions is when the child comes in. In my reward systems, there's a rule that if the parent within 24 hours doesn't reward the level 1 reward, and within 48 to 72 hours, the level 2 reward, and then I sometimes go to level 3 depending on the complexity of it, that the child gets double the reward. One of my favorite moments is when the kid comes in and says, "Mom didn't give me the reward I was supposed to get." And so the child starts policing the parent. Those are fun moments. So you got to find some of the humor and the levity in these moments of, how hilarious some of these worries are, how inappropriate and how wrong they are. Again, I use a lot of, I worked at a kid's pizza place in my earlier days when I was in high school in the States. So when I was doing that back then, I learned all these stupid magic tricks with sleight of hand and coins and rings and stuff. And so I bring a lot of humor and magic into my office. I do a semantic trick with knocking down a wall in my office that gets every kid, busts them, and I wager them. So I use a lot of humor and sort of gimmickry and tricks like that to get kids really engaged in treatment. But I think that's with every kid case I work on. I think just being able to do that and keep some humor and some lightness in the process. Sometimes with, I see kids who have harm OCD, and we do exposures where kids are, putting knives up to their necks and mine, and and doing what looks like scary things, but safe things with scissors and sharp objects. Stuart, it's a real challenge when you're working with very difficult, tough topics to keep everybody's spirits up. But talking about progress, concretizing progress, focusing on rewards, having people sometimes just come in and just talk about how difficult things are, validating and normalizing their struggles, and reminding people that, you didn't, for most kids, most adults, you didn't get here overnight. It's going to take a few sessions and a lot of practice to get there. But on those good days, to remind people to document them, to have video clips of them, to take selfies of them. I think that's the precious part of therapy, is to make sure that we're acknowledging the successes and the real milestones in that. But that's a generic answer for therapy in general. I mean, therapy, for a lot of people is a grind and it's tough. But if you're on this side of the room, I know people don't sometimes love coming to therapy. I love meeting new families. I hate seeing the struggle, and I love seeing them on the other side of it and realizing that they don't need to go find the next therapist, because hopefully if you get good CBT and ERP treatment, they found their last therapist. That's my goal. Early intervention is everything. I know that you and I love treating people of all ages, but I want to treat kids so they don't become anxious adults and anxious parents. That is ultimately my goal. We joke about it, but I don't think I'm going to be out of business, but I'd like to put adult therapists, which I'm an adult therapist as well. I'd like to put adult therapists out of business and eradicate, a lifelong of anxiety. Early intervention is the key. In fact, the research is undeniable that kids who are anxious, who don't get treatment, struggle as young adults and adults. And kids who get early interventions for anxiety look like the healthy teens and adults. And I love that. So, all the things that we talk about, all the things you do in your podcast, all the empowering messages, all the advocacy work out there, the videos like Unstuck, there are so many positive messages out there. And so sometimes a therapist needs to bring all that together and just show that to families, because we're all fighting for the same thing: to be healthy, to be joyous, and not to be anxiety free. I am not here to teach people to be anxiety free. I'm here to teach people to live with anxiety and feel empowered and in control of their lives. And if they have that, then they're doing better than people who have their head in the sand. Yeah,
really good point. Okay, so couple different questions now. So last time you were on, I asked you advice for your 20-year-old self. So now I'm going to ask you advice for your 30-year-old self.
Oh, you did that, didn't you? My 30-year-old self. Where was I when I was 30? Okay. So my 30-year-old self, my advice to me would probably be follow your gut. My personal and professional intuition. So I was at an interesting time in my career where I made a major change, and I knew what I wanted to do, and I was trying to do a lot of it where I was, and I decided to make a quantum leap. And I remember, actually, wow, this is taking me back quite a bit. I had a lunch with my father, who was the greatest man I ever knew. And I remember he was a consultant at the tail end of his career. And when I was 30, I just was on the cusp of, I just finished graduate school. I was looking at two different job opportunities, and I was really shifting. I went from what I was doing in graduate school to getting more into this space in my career. And he gave me some advice of what do you really want to do? And there was things I thought I was supposed to do, and I did them, and I don't regret that, because it took me here. There's things that I wanted to do. And so I probably didn't follow my gut, and I did what I thought I was supposed to do. And I followed the traditional academic path, which I don't regret. I learned a lot, made some amazing colleagues, but it's not what I was supposed to do. But it's honestly what I thought, and what a lot of graduate students are sort of trained what to do. You go to graduate school, you're following these amazing academic people. What do? You follow their lead and you go to graduate school. You get an academic job. And so I remember my father in a cafe, after I told him what my first job salary was going to be on postdoc, which was abysmal. He said, "Well, but is that what you want to do?" And I said, "Well, this is my dad, and I'm supposed to be the therapist. What is he doing? Give me this advice." And I ended up going for what I thought I was supposed to do, and it's not what I thought I really wanted to do. And rarely in my career, and rarely in my personal life, has my gut been wrong. And so I went against my gut. And again, I don't regret the career path. I've had a bit of a circuitous path to get where I am, but it taught me a lot about medical. I did a lot of work in a health psychology space. It taught me a ton about medicine, which, as most psychologists, we don't get training in. And so it was a great learning experience for me. But again, it wasn't what I was supposed to do. It's not what I was loving doing, but it's what I thought I was supposed to do. So I would tell my 30-year-old self, listen to your gut, follow your passion, do what you really want to do. And anytime I've done that in my career, and I have a pretty exciting career I'm quite proud of, I have never regretted it. When I've done things I thought I was supposed to do, and I've always benefited from them, I probably have had regrets at the time. So listening to my gut, my instincts, and following that and following my passion has never guided me wrong. And I think, living proof of that now. I love my job. I have lots of friends, guy friends who I adore, who I'm sure don't love their jobs. I could not imagine. I have one of the weirdest, coolest, best jobs ever, and I get to help people and sometimes be one of the last people that they get help from. Stuart, I know you're trained to become a licensed therapist. I hope you fulfill that and do it, because it is, I love my career. I'm very honored to do it. So long-winded answer to a very simple question. I apologize.
No, I like it. Yeah, I can see similarities in my own life. Yeah, no, thank you for sharing that. And then you did answer this before, but I'll ask it again. Is you got a billboard in Atlanta? What do you want written on it?
Oh man, do I use this as a selfish opportunity to put something out there or not?
Yeah, go for it.
The first billboard in Atlanta I say is Ellen DeGeneres, ping me. So I use a lot of comedy in my practice, and sometimes too much. I have followed stand-up comedy for years, and I assume she's huge worldwide.
Yeah.
I have followed her for my entire really adult life and even in teenage years. And she just, to me, represents everything that's beautiful in the world. I can't believe I'm saying this. This is truly not, I can't even say it's not scripted. This is I'm getting red in the face right now. But I love her. I love everything that she represents. I love her show. I love the way in which she used media to come out. I love the way she empowers other people. I love how kind she is. I just think she's the most amazing person in the world. So I would absolutely selfishly use the first billboard to say, hey, Ellen, ping me. I'm not going to put my number or email out there, but I have my bucket list to have lunch with that person one time in my life. And I just think she's just the most beautiful human. I don't know enough about her personally, but what I see out there and what I follow about her, she represents kindness and compassion and patience. And so I think the second billboard would be, which is what she represents, and I think I probably said this last time, is just be kind and be compassionate. Anxiety is a disgusting, evil, heart-wrenching disease. The moments I have failed as a father to my daughter, the parent of an anxious child, is when my compassion went out the door. And the moments that I have been most successful, even in her worst moments, is when I just sat with her and watched her. And Stuart, as a father, I'm getting a little choked up saying this, it's the hardest thing to do, to watch your child suffocate. And so in those moments when I am compassionate towards her, and, ironically, like most of us, I have no problem doing it to the kids in my practice here, but me being more compassionate to her and me being more compassionate to myself and my wife and I being more compassionate to each other, and just knowing that we are doing everything we possibly can to, help her and everything I'm doing in my practice, sometimes forgetting to remind yourself that, you're doing the best you can with whatever you have in that moment. Be compassionate and be as kind as you possibly can. That is my hope for everyone who listens to everything that you do. You exude it. Your people who come on as guests exude compassion and kindness and empathy. It's what I adore about Ellen DeGeneres. It's what I try and do. I know I'm not perfect at it, but just be kind to other people, be benevolent, and things get easier when you do that. And so that would be my billboard. Just be compassionate.
Yeah, I like that. Two good billboards, and you never know, maybe Ellen does listen to this podcast, and if she does, ping me too and get me on the show, because it will help me reach more people.
Ping Stu first, because he has bigger reach than I do, but invite me along.
Okay, I'll get you backstage.
Good deal.
Okay, cool. Is there anything else that you haven't shared that you wish you could today?
Yeah, one or two just resource things out there. Yeah. There's some really good resources for parents of anxious kids, parents with OCD. There's IOCDF has put out a series of websites within their iocdf.org website called Anxiety in the Classroom. And I think they in fact, I'm pretty sure they have a teacher-focused version, and they're going to be launching a parent and a student version, sort of hitting the three elements of anxiety and OCD in kid populations. And the Anxiety and Depression Association of America.org has a bunch of good resources about kids with the pediatric OCD stuff. I get asked all the time, what are some of the good books that are out there? I get no proceeds. I get no plugs. This is just what I have in my practice. I'm going to have them sitting right here, as Stuart can attest to, as I'm showing him as we're talking here. But I adore Tamar Chansky's book. It's not the most ERP focused, and that's okay, but it brings the best of science for kids, parents, OCD. I love John March's book, Talking Back to OCD, a program that helps kids and teens say no way. I think it's a really good one. I have right here. It's definitely much more of a workbook. It's thick, but it's a good one. It's been around for a while. And there's some great clinical clinician books out there. A lot of books that parents buy. There's sort of a self-helpy kind of cutesy, cartoony book. I have right here. There's a few of them out there. I don't know the authors, but these are really good, kind of more junior kind of kid books for like the 5, 6, 7s. What to do. This one's what to do when your brain gets stuck. A Kid's Guide to Overcoming OCD. There's a few of them that have the same art look to them. Unstuck video, if you haven't seen it and you're a parent or a clinician or a kid who has OCD, please go see it. It's an amazing video. And someone who I've never met, I've seen a few things on her on Facebook and online from what I've seen from her. And she's an LCSW in California. I don't know her professionally. I get nothing for this. But a woman named Natasha Daniels, I don't know if she's been on has she been on your podcast?
No, but she's coming on it.
She is the real deal. She is amazing. I need to connect with her. I watch some of her videos. She puts out great videos on all. She has a website and a series of AT, I think, anxious toddlers, tools for parenting the anxious child. She's what I want to be when I grow up. She really has taken everything I think I've shared about today and put it out there in a very user-friendly, palatable way for parents of anxious kids to use, of all different anxiety disorders. She has a good style to her. She's very easy to watch. She's really thoughtful, and has a whole series of stuff on Facebook and videos. So again, I don't know her professionally, but I think the world of her. I've watched some of her stuff and used it personally. I just think she's amazing. So any parents that are looking for some really great resources that are on the web, I'd go there. So just want to share a few extra resources, as not every person can get to a therapist or can access a therapist, but most media resources online are accessible worldwide. So I'd encourage people to search that stuff out. And this is my second rendezvous with you, Stu. So I have just nothing but mad props for you. It is a privilege to sit on the microphone with you. I love your work. My patients love your work. You are doing what most of us want to do, and that's just to get the word out there for the best of the best. And for that, I'm grateful to having spent now 2 sessions with you. So thank you very much.
No, thank you. Going to make me blush. No, I appreciate it. And all the links to everything you mentioned will be on theocdstories.com. So just thank you so much for your time. This is a topic that's close to my heart and one I care deeply about. So it's great to go in detail in it with you.
My pleasure.
So there you have it. Thanks a lot to Josh for giving him his time, and thank you to you guys for listening. And if you get a moment and want to leave a review on iTunes or wherever you listen, I deeply appreciate that, as it helps me reach more people. And quick disclaimer, guys, this podcast is not therapy. It's not a replacement for therapy. Please seek treatment from a trained professional. Until we speak, take care.